Moving to our next session, I invite Dr. Parthan Joshi sir. He is a urologist practicing in Ahmedabad and has received many medals and awards in field of urology. And he will be enlightening us on revolutionizing urology, innovative technology transforming patient care. Over to you, sir.
Thank you, IMS Surat, for this opportunity. And we discuss about transplant a lot. I've been visiting Surat for organ retrieval, along with the liver team when we retrieve kidneys. I must salute the city of Surat in general and the medical fraternity here for setting such a high benchmark for organ donation, which is an inspiration for rest of the India. I congratulate you all for that. So I'm talking about what recent advances that we are trying to utilize in urology. We as a urologist feel that we are early adopters of newer technology for miniaturization and better patient outcome. I did my MBBS from Ahmedabad, the MS from Baroda, and my MCH from Bangalore. I must tell that there are no financial disclosures to be made, since I'm going to talk about proprietary branded instruments. So there was a time when patients would always ask us कि कितना टाका आवश्यक surgery वक्त है. So they would understand that bigger the incision, bigger the surgery, or more complex the surgery. So miniaturization started in 90s in form of laparoscopic surgery or hand-assisted laparoscopic surgery. Then the benefits that were achieved were faster recovery, less blood loss, faster back to work, and loss of working days were reduced. When we, as a fraternity, shifted from laparoscopy to robotics, we utilized these 3-4 key advances, that we now had a 3D vision, we have a magnified vision, and the problem was there was no tactile sensation. Although there are robots in development now which are aiming to give tactile feedback to the surgeon's hand, but we don't have them in service yet. Now, they would say the future is nanotechnology. We have heard about how countries are weaponizing technological tools for damaging each other. I am sure such applications can be used for benefit also. So these are the things we do with robotic surgery in urology. So we do nephrectomy, partial nephrectomies, adrenalectomy, pyeloplasty. We do various reconstructive surgeries and a host of ablative surgeries like prostatectomy. I would say out of these all surgeries that we can do robotically, many of them don't really need a robotic surgery. But where it really shines is in radical prostatectomy for radical excision of prostate, and partial nephrectomy, where we are trying to preserve as much as normal renin parenchyma in a kidney which has tumor. So this was the evolution. The company right now also has a market leader spot, but it was not always as developed. And my colleague Dr. Vaishnav sir already talked about how they are utilizing the latest version of this robotic system for complex GI and pancreatic surgery. Now this is the standard that we have. What we would proudly say it is the latest machine or the best machine, but there is a time when we also will not be the person having the best. This is what is called as a Da Vinci SP, special purpose robot. Now this is it is utilizing a single port advantage, where all the instruments are introduced in the abdomen with one port, and they fan out like a adder head or a sheshnag, and they spread their instruments, and you can utilize a single port for doing all this complex surgery that we are doing. Different types of hand instruments have come where different tasks are done. A gynecologist would want a speculum or a tenaculum more than a urologist would want. So different specialties are developing their own hand instruments for their purpose-built process during the dissection or tissue ablations. we already went over some of the benefits, and since next what we are looking at is lunch, I'll go through some of these fast. This is a demonstrative video of partial nephrectomy and radical prostatectomy, where we actually utilize the technology to give better patient outcome. In partial nephrectomy, the idea is to preserve as many nephrons as possible, because many a times these patients have bilateral tumors, or elderly patient with compromised kidneys, or CKD patients. Whatever normal parenchyma we preserve will delay or prevent the patient being on dialysis. So that is a big help for them. But while we are trying to preserve the normal parenchyma, the idea is to completely remove the tumor and have a negative surgical margin. You can utilize different instruments for different tasks. Here we have ligated the vessels. Now you can see the renal artery getting isolated. The precision of movement that we can achieve via robotics is difficult to reproduce in laparoscopic surgery, especially for newer starting surgeons. So I am sure there are one or two excellent laparoscopic surgeon in each city, but then they can only operate on a certain number of patients. So more patients getting better surgical outcome is possible. So here we have the tumor in the view. You can see the tumor, a round shape distinct to a normal renal parenchyma around it. Now we are going to mark the area around the tumor. This is arterial clamp. We tend to keep the warm ischemia time of the kidney as less as possible. Now when the clamp is applied, renal arteries are occluded. You can see that the whole kidney has gone pale along in the tumor area. While cutting off the tumor, we make sure the rest of the parenchyma is preserved. And now what we are left is a hole in the kidney, which is to be repaired with rhinography. Many a times, because of the size and location of the tumor, we may inherently end up cutting one of the segmental artery or pelvic calyceal system, which can be easily repaired like one would repair in an open surgery with a figure of 8 stitch or hemostatic continuous stitch. During the surgery, you can see there is one arm on the right of the screen continuously holding the kidney in place. So the concept of traction, counter tractions are better utilized with extra number of instruments that we have. Now we have started the outer layer of rhinography. We are keeping the sutures in place and in tension with help of surgical Hem-o-lok clips, so that stitches don't get loosened up and start bleeding or leaking urine from pelvic calyceal system. So this is a doctor using a laser gun. So we were, I would say, now a lot of specialties are using lasers. Urology was one of the early adopters where we started pulverizing stones with lasers. With endoscopic surgery, the need for open surgery or large incisions were no longer needed. And no matter the size of the stone, with newer models of laser with optimal energy delivery, we are utilizing the laser to remove the stones. So what is new? Laser for ureteric or renal stone has been there for more than 10 years now. So recent one type of laser is thulium fiber laser. Here the efficacy of stone fragmentation is higher, and there is minimal collateral damage. Now stone dusting or stone pulverization also have, with time, a lot of techniques have come up. Different people have fiddled with the laser and tried to handle the stone in different way. One of the newer technology, what they are using is Moses technology. Moses is a historical figure in Judaism who famously parted the Red Sea for their people to travel. So similarly, what we have done here, or what the company has done here, is they produce a large air bubble which separates the water, the irrigation fluid in front of the stone, and optimal delivery of the energy is done to the stone. We also use lasers in uro-oncology. Here we are utilizing a laser fiber to do an en bloc resection of a bladder tumor. The bladder tumor is completely removed without handling it. So this decreases the chance of tumor seedling in the rest of the normal bladder mucosa. So PCNL, percutaneous nephrolithotomy, again, it's been around for 20 years. The biggest problem is that patient has to be put in a prone position, and there are problems associated with the positioning, and anesthetists really hate this procedure because they have to handle all the lines while we are juggling the patient on the table. So now we have started doing supine PCNL. The patient is put in a lateral position and we are utilizing the lateral clavicular line for insertion. Now the advantage is, apart from lower operating time and need for handling of the patient, the most important thing is we can do a simultaneous endoscopic access per urethra also. So a ureteric stone and a kidney stone can be handled at the same time, or we can do what is as catch and release, as in American football or rugby, one person will hold the ball, run it for certain distance and pass over to the second player. Similarly, an endoscopic surgeon will pull out the stone or stone fragment from a difficult to access calyx and hand it over to the other scope. AI is the revolution that we are facing now, and there was a time pre-COVID era in late 2018, 2019, when pathologists got a real scare. In uro-oncology, the prostate biopsy samples were analyzed by AI as good as an experienced oncopathologist would. So we all thought that we might lose out our jobs to AI. But what we have realized is that it does not take our job. If we apply the principles and we try to ask AI to do the job that we don't want to do, that we rather would be doing something more interesting or more rewarding, and we can utilize AI for a task which was repetitive or less interesting to us. So what has happened is it has been used in R&D a lot. So newer drugs are coming up. Then we have started doing precision targeted therapies for uro-oncology. All this because AI and other tools that we have used for machine learning, they are doing repetitive tests that a pathologist or a scientist would be spending years to do. They are doing it in matter of days or weeks. So we are getting new and new drugs. If you can just imagine the number of new drugs that has come for oncology, and especially for targeted therapy, it is amazing. So as a clinician, what we are doing is we are improving physicians' efficiency and efficacy. We can remotely monitor and even now remotely operate in certain cases with the right equipment. Then we can integrate data and learn from data that anyone who has done a thesis during residency would imagine how those last couple of months were for analyzing data and going to and fro from thesis. So among all this, what has come out is augmented reality. So it is little different from artificial reality. Artificial reality is completely imaginative. So this was artificial. This is used image generator. So what we do is you have all heard of ChatGPT, right? So it is a text-based interaction with the machine learning software. Now some companies have come up with image generators and video generators as well. I'm sure some of you would have seen how fake videos are created for politicians and celebrities. So an image is generated out of thin air. Just I have given a prompt. I have just said I want an image where doctors are working on AI. So this is the image that was generated. So this is artificial intelligence or artificial reality. But in augmented reality, it augments the real-time image or the physical present things and add a layer over the real-life structure. So if I can tell you, we just saw a surgery of a renal tumor with partial nephrectomy, robotic partial nephrectomy, where the idea was to remove the tumor completely, not a single bit should be left behind, and to preserve the normal renal parenchyma as much. Now, how can we utilize augmented reality for that? So for that, what we do is we have a imaging technology in the camera of the robot or the vision system that continuously shows the video of the structures inside the patient's body. We have pre-operative imaging in terms of either CT scan or PET scan or an MRI. So everything is compiled in the processor, and ultimately what the surgeon sees on that medical monitor is the image of the tissue as well as the augmented layers over it. So I'll give you the example. This is something what we saw in the video, right? This is an image that we see. We see renal artery and renal vein have been identified and looped for surgical steps. And you see renal kidney surface. Now all these tumors are not exophytic. Some of them will be inside the parenchyma, not visible from outside. But now once we try to superimpose the structures, this is what we see. We see the venous system in blue. We see arterial system. We also see collecting system and the areas where the calyx is, where the urine is stored. And we also see tumor. So while we are resecting the tumor, we are sure that we are removing the tumor alone, nothing else. One more enhanced imaging is narrowband imaging. This is an image of a bladder mucosa. We have done a diagnostic cystoscopy for a patient who was operated before for bladder cancer. He has come to us for follow-up. And on your left you see a normal white light image, and what you see is congested mucosa. It is very difficult to identify a recurrence or an area of congestion. But on your right you see a narrowband image where there is a distinct area of red color where there is vascularity has increased. So this tells me that there is a suspected lesion there, and it would help me in target that area for biopsy to confirm recurrence. One more way of knowing the tumor margin or whether we have resected the tumor or anything is left behind is called Firefly. This is where we give intravenous dye and we look at the kidney. So we have 4 different image types of a same lesion. The kidney with the tumor looks different in different categories because the dye is circulating in the renal parenchyma and the microvessels. This is an out of the body image of the tumor where you can see the tumor is illuminated and normal parenchyma is not seen. So this is just for demonstration. This we don't do in a live case, but later on if you want to confirm before the pathologist tell us the biopsy report, we can see whether we have removed the whole tumor or not. Let's talk about prostatic urethral lift. So I see a lot of elderly gentlemen here, and so I tell my patients that every male patient has a prostate. Everyone will suffer some degree of urinary discomfort because of rise in the size of the prostate gland. Now, the standard of care right now for 90% of patients is medicine. When medicine therapy fails or there is a specific indication for surgery, the standard of care right now is TURP or HOLEP. So holmium inoculation or TURP. For certain group of patient, now what new thing has come is nothing but like an implant. So these are clips which push the prostatic adenoma laterally and clear out a passage for urine to pass. So this is the before and after image. Here the lateral lobes have been pushed laterally. So the left lateral gets pushed laterally and right lateral lobe gets pushed on the right, and clear passage is achieved. And the beauty is that you can see an intact bladder neck. So obviously we know that male have 2 sphincters, external sphincter and internal sphincter. So one is at the bladder neck level, which is completely preserved because we have not touched it. In TURP we would definitely resect it. And this is the original study, the company-sponsored study which was done initially, where they found that the overall patient-reported outcomes are similar to TURP for prostatic urethral lift. So what are the benefits that we are trying to achieve here? So let me tell you, this is not a replacement for TURP. It does not make TURP obsolete. This is for select group of patients who may benefit more rather than other patients. So obviously it takes smaller amount of time. We don't have to stop blood thinners for these patients. This can be done under local anesthesia also. And bladder neck is preserved. So the ideal patients are typically who are very young and they are concerned about their ejaculatory function post surgery or their sexual function post surgery, and someone who is very old, very frail, medically unfit, lungs are bad, cardiac unfit for surgery. These are the patients we can utilize this surgery for. And the last is for stricture urethra. So stricture urethra is a dreaded disease where the old dictum was once a stricture, always a stricture, which is still true. It is difficult to give 100% results for. I'll take 1 more minute to conclude, hopefully 60 seconds. So the best outcomes are through buccal mucosal graft urethroplasty. We take buccal mucosa from the inner aspect of the cheek and use that for augmenting the urethral lumen. This is obviously a very morbid procedure both in the perineum as well as the oral cavity. So what the new thing has come is, it's a trade is called regrow or urogrow. So we are utilizing the best or the better parts of buccal mucosa graft urethroplasty. Here we are just taking a small sample of the buccal mucosa. The lab is processing it. They usually give it back to us in 10 days. And we have a suspension of basement membrane of the epithelial cell of buccal mucosa, which we can inject at the site of stricture incision. So we can treat this patient endoscopically but take benefit of a buccal mucosal graft surgery. Thank you for your time and thank you for...
Thank you very much, sir, on eye-opening session on the incredible technology advancement in the urology. To felicitate Parthan Joshi, sir, I would like to invite Dr. C.B. Patel, Dr. Yatish Lapsiwala, and Dr. Mansukh Gatiwala on the stage, please. These are renowned faculties are there in the lunchtime also. So if you are a query, please ask at that time, because we are a little bit short of time. That's why. Okay.